Thank you for joining us tonight. I'm looking forward to a really interesting and informative presentation and then followed by a discussion. And in order to let that happen, I'm going to stop talking and introduce Howard Glazer, who's an old hand at this and our moderator this evening. Howard?
Thank you, Kent. Welcome, everybody. I want to first remind all attendees that our program tonight will be for 90 minutes. And I thank both Dr. Weinrib and Public Health Commissioner Harris for providing so much of the valuable time to us. We're going to conduct the meeting tonight in a virtual professional medical or nursing scientific meeting format. With that, I mean this. Dr. Weinrib and Public Health Director Harris will each deliver slide presentations on the important medical and public health science aspects of COVID-19, respectively. This will then be followed by a moderated question and answer panel with the two speakers and you, our attendees. This is very important. Please, to submit a question, use the chat function in Zoom and send your question privately to me, Howard Glazer. I will then ask as many of your questions to the speakers as time permits. If there's a need for me to ask you to follow up with the speaker, I'll have you on mute, see if you have any more questions, but we'll try to get as many questions in as we can. Thank you for that. I would now like to introduce both of our esteemed speakers. David Weinrib, MD, is an infectious disease specialist at Atrium Health Carolinas Medical Center since moving to Charlotte in 1995. During the last 25 years, David has also been on the faculty of the Carolinas Medical Center Internal Medicine Department and is a clinical professor of medicine at the University of North Carolina Chapel Hill School of Medicine, teaching both medical students and internal medicine residents here in Charlotte. David graduated from Brown University in 1985 with a degree in history, Phi Beta Kappa, and received his MD degree in 1989 from the University of Alabama, Alpha Omega Alpha, the Honor Society for Medical School graduates. He then completed his internal medicine and infectious disease training at the Beth Hospital in Boston and the Harvard Medical School combined program in infectious disease in Boston. Over his career, David has been co-investigator in many NIH-sponsored and pharmaceutical-sponsored clinical trials of HIV antivirals and currently is involved in clinical trials of multiple investigational drugs for COVID-19 illness and emergency use authorization treatment with remdesivir and COVID-19 convalescent plasma. Gibbie Harris has been the director of Mecklenburg County Health Department since 2017. She has served as the incident commander for the county's COVID response to COVID-19 since the beginning of the pandemic. Previously, she was the health director in Buncombe County for 6 years and in Wake County, serving as a health director for 10 years. During her tenure in Buncombe County, the county won the Robert Wood Johnson Culture of Health Prize. In addition, Director Harris was the founding executive director of the hospice program and a nurse practitioner at a rural health clinic in Wilkes County. Public Health Director Harris graduated from University of North Carolina Chapel Hill School of Nursing with a bachelor's degree in nursing and a nurse practitioner certificate, and also from the renowned UNC School of Public Health with a Master of Science degree in Public Health. That's a little thumbnail sketch of both our speakers, and I'd like to welcome Dr. David Weinrib to give the first of the two slide presentations. Thank you. It's all yours, David.
All right, so I've got a share screen, and hopefully this is looking, can people see this?
Looks good.
Great. So I'm going to just acknowledge to start that these slides are mine. I've also had the benefit of sharing some slides shared with me by some of my colleagues, Katie Passaretti, our head of infection prevention, Dr. Chris Polk, who's really in charge of our research effort on COVID, and Dr. Lisa Davidson, who's the head of our stewardship program. So we work as a team there, and I appreciate them sharing some of the slides. This is a picture of what I am looking like these days walking around. When I see patients, I wear a gown, a plastic disposable gown, but pretty much our PPE is goggles in addition to surgical mask and wearing an N95 mask underneath that if we're seeing COVID patients who are in rooms with aerosolizing procedures. So we can't cover everything in the world of what's interesting in COVID-19 for medical insights, but I thought people would be interested in these topics, and I'm going to do my best to touch on these in the short time I have. First is, what's the spectrum of disease and how many patients really are asymptomatic, which I think is a big question a lot of people have and we don't have full data on. Secondly, what are the risks of serious complications in terms of what are those clinical or other epidemiologic risk factors? How is COVID-19 different from seasonal influenza? What are our current treatment approaches? You may be aware that many people are having prolonged time to recovery or ongoing disability. You know, this disease is very new. We're just a little more than 6 months into it, but there's some people who are having long courses of ongoing symptoms before return to health. And then I'll touch briefly on some thoughts on vaccine prospects. On the topic of how many people are asymptomatic, we really don't have clarity on this yet. Part of the problem is that when data are published on patients with positive tests but no symptoms, it blends those who remain asymptomatic from those who are pre-symptomatic, meaning at the time of the test, when they're evaluated, they have no symptoms, but they go on to develop symptoms subsequently. So there's a lot of uncertainty around this, but this is a very important question. I think the best number is possibly 25%, taking the whole group of people in the population may have asymptomatic subclinical, meaning they don't seek medical attention because they're so mild. Their illness is so mild that they either have no symptoms and they don't know they're infected, or it's extremely transient. And knowing this number is important because until we have a good denominator number of how many people have had COVID by serologic testing in well-done population-based studies, we will have a really difficult time getting our mind or our understanding around what's the true mortality rate and have a good sense of the total picture. The general overview for the timeline of the illness is that the average time from exposure to onset of symptoms is around 5 days, but we know that there is a wide range, and therefore 14 days is our normal recommendation for isolating after exposure to cover an outlier. Once there's the onset of symptoms, the most common symptoms are fever, cough, fatigue, loss of appetite, which is what anorexia means, muscle aches, which is what myalgia means, and some people get diarrhea. And the most serious illness tends to happen at 5 to 7 days into the second week of illness. So most of the people who are sick enough to land in the hospital, and certainly those who are critically ill, are typically by that time more than a week into the illness, often really closer to 10 days or into their second week of illness. And of course, some people have such a mild illness, they never have that more severe phase. But I think it's, we really don't know how sick a person's going to get until they've gotten beyond that day 7 phase. And we can get a little bit in a minute into how we identify who's at risk for getting sicker. So the word morbidity means what are the illnesses, mild to severe, that people get. Mortality means death. And in general, the mild to moderate symptoms covers about 81% of those who come to clinical attention with COVID. So those numbers ignore the people who are completely asymptomatic and don't even get tested or don't even know they're sick. Severe disease, meaning they require significant amounts of oxygen, or on chest X-ray or chest CT, there's more than 50% of lungs involved with these inflammatory or pneumonia changes. That's about 14%. And then critically ill, requiring ICU care with inability to breathe on their own, requiring going on the ventilator, or shock, which means low blood pressure, or multiple organ injury or failure. That's about 5%. And of that 5%, half of them will die. At least that was the number earlier in the epidemic, and we still have a lot of people who are and the true numbers in the last few months in terms of mortality for ICU care, a little less clear. It's probably a little lower than that, but I haven't seen any really great numbers. So our current best estimates in the United States for the mortality rate from this disease is somewhere between 0.25% to 3%. So that's a pretty wide range. And I think that kind of reflects some uncertainty about what is that larger denominator of people out there. And as you'd expect, there are groups that have much higher mortality rates. And of course, in resource poor regions, the numbers are probably worse. So the risk factors for getting very ill with COVID, the strongest evidence is on the left here. It's with cancer, especially advanced cancer, advanced kidney disease like people on dialysis or pre-dialysis, patients with advanced chronic obstructive lung disease like emphysema or chronic bronchitis, patients with significant heart conditions like congestive heart failure, coronary artery disease, with chest pain, angina, or heart attack history, or a weak heart, which is what the word cardiomyopathy means. And then we know people who are obese or severely obese, as with influenza, or at significantly higher risk for respiratory failure leading to going to ICU. Sickle cell disease, smoking, solid organ transplant, and type 2 diabetes are all the round out the conditions with the strongest evidence for risk for severe disease. On the right, there's more limited evidence for risk factors for severe disease, including pregnancy, patients on immunosuppression like prednisone more than 15 or 20 milligrams a day, or other biological immunosuppressives used for a number of rheumatologic and other conditions. And then people with a history of cerebral vascular disease are at risk. And then on the lowest end, there are some conditions that are surprising that there's not more evidence. As an infectious disease doctor, I take care of a lot of people living with HIV and AIDS. A lot of them are worried, but so far there's really not been a significant signal that these patients are at higher risk for bad outcomes compared to these other conditions we've mentioned above. Age is a major determinant of poor outcomes. So if you just really, this is from over 600,000 COVID cases from China, Italy, Spain, United Kingdom, and New York State in the first months of the epidemic. And if you just pay attention to the red line here, you can see that by decade, as you go from persons, the inflection point for worsening outcome is around age 50. In the 50s, the mortality with COVID is about 3%, up to almost 10%. If with people in their 60s, almost 23% people in their 70s, and almost 30% people over 80 years of age. So age is clearly a major risk for poor outcome with COVID, taking all comers around the world. And another way of looking at that is this data from the United States, looking at risks of hospitalization and death by age group. And if you use young people between 18 and 29 as the comparison group or reference group, the younger people are much lower at risk for hospitalization and death, and people in progressively older decades have much higher risks of hospitalization. So an 85-year-old is 13 times more likely to need hospitalization compared to a 18 to 29-year-old, and over 600 times more likely to die compared to a young person. So our current approach reflects our understanding, as well as the fact that we've got very limited numbers of drugs that have been proven to help. But I think this chart shows what our current understanding is of what's happening in the body and what's the relative responsibility of the virus counts and the activity of the virus, which is really in the first week or two of the illness. And for the patients who get progressively sicker with worsening pneumonia in stage 2, and then in stage 3 with multi-organ system problems, really what's taking over is a unhealthy, exaggerated host inflammatory response. And in doctor talk, the word inflammation means the effect of the body's different parts of the immune system that's designed by nature or designed by God to fight infection, to fight injury, and to help prepare the body. But when it goes wrong and it gets aggressive, it can cause worsening organ damage rather than being helpful. So our approach to treatment when patients first show up is mainly, we think, antivirals. So remdesivir has been tested in patients mostly requiring oxygen and in the ICU. But here at Atrium Health and around the country, we are starting clinical trials for remdesivir in people who have not yet been hospitalized, in people in earlier stages of illness, to see if it's helpful in preventing admission. Similarly, the monoclonal antibodies, there's a couple that are being researched right now. You may have heard that President Trump received the monoclonal antibody from Regeneron at Walter Reed Hospital. It was not stated he did that on a clinical trial. If it was on a clinical trial, he would have gotten placebo or monoclonal antibody. My guess is he was not on a trial. There's another monoclonal antibody from I believe, another company that Eli Lilly, that just had to pause their trial because of one subject had a bad outcome, but that doesn't mean it's off. It's canceled. It just means they're pausing that study to investigate what happened with that patient. But the concept here is that by giving monoclonal antibody that is what we call neutralizing antibody to try to neutralize the virus in the blood, because this is the phase where the virus is very active in the blood and in the lungs, we're hoping this will help clear the virus more quickly and be favorable for the patient. And that's also the concept for convalescent plasma, which is donated blood from people who've already recovered from COVID. After about 3 weeks, their blood is rich in antibodies at varying levels, and there is not conclusive evidence, but the FDA has made convalescent plasma available through what's called emergency use authorization, as it has with remdesivir. Most of us have been using the Mayo Clinic convalescent plasma trial, and this is widely available across the country. How much that helps is a bit unclear. I think there's reason to hope the monoclonal antibodies might be more helpful. In the second phase of the illness, where the inflammatory concerns are greater, this is where dexamethasone has been shown to be beneficial, and there are good randomized studies that show this to be beneficial. So it's used typically for 10 days in people who have a significant oxygen requirement. And in research are various other drugs in various parts of the inflammatory cascade, or attacking various inflammatory mediators to tap down the inflammatory system. None of these have yet been proven to be beneficial. Some are in phase 3 trials and phase 2 trials. So we're hoping we will have studies published that will make this, that will greenlight some of these, and these can then become more widely available. The relative contribution of antivirals and monoclonal antibody late in the illness is controversial, again, being studied. We really need data to know this. And at the bottom of this, it shows some of the blood tests we use to monitor inflammatory response and to try to predict who is having a bad time or is at risk for progressing quickly to a worse phase. I'm going to talk now about recovery and long-term complications. People in ICU with severe illness usually take about 3 to 6 weeks to feel substantially better. Symptoms can also persist in milder cases in people who never get hospitalized, so that what's been published in the MMWR, which is a bulletin called Morbidity and Mortality Weekly Report from CDC and from JAMA recently, is that about 40% of patients' symptoms, only 40% of patients feel substantially resolved at 21 days, and that there's a lot of patients with milder symptoms tend to feel better sooner. The more severe symptoms, fewer patients feel better. The persistent symptoms are mainly fatigue, shortness of breath, cough, joint pain, chest pain, confusion, anxiety, depression. And there's been a lot of press around certain complications like heart muscle inflammation, myocarditis. It's been described in college athletes, It's been described we've seen this in our hospital in people of different ages. And, because this is all a new condition, we're not really sure what the duration of this is and how disabling it's going to be. Some patients who had to be on a ventilator have scarring in their lungs and have ongoing oxygen requirement and a long road to recovery. And then as with any critical illness, there can be a post-ICU syndrome with generalized muscle weakness, confusion. The last topic on this I'm going to mention are what are called COVID-19 long haulers. Of course, we're only 6 or 7 months into this illness, but a lot of the features of this are looking similar to what we've heard of before with myalgic encephalomyelitis or chronic fatigue syndrome. It's not limited to critical illness. It has occurred in people who've never been hospitalized. The ratio of women to men affected seemed to be about 4 to 1. And there are various theories not yet conclusively proven over what is the explanation for this. So you can read here some of the words. Endothelial dysfunction has to do with how blood vessels properly function or don't function. The autonomic nervous system has to do with the sympathetic and parasympathetic control of our nerves, our circulation, and our endocrine system. Mitochondrial dysfunction relates to how the mitochondria in our cells, which are the energy producing parts of cells, work or don't work well, and then immune derangements. We're all very concerned about the confluence of seasonal influenza in the winter and COVID-19. I thought this cartoon was cute, showing 2 twins who look like they're out of the Addams Family, asking you to come play with them, COVID and flu together. There is a hope, I think, that we may be looking at the mildest influenza season we've ever had based on what's happening in the Southern Hemisphere. I've seen an article as recently as a couple of weeks ago that Australia has had a relatively light flu season, maybe in South Africa too, and I think that's all predicated on high uptake of the influenza vaccine in the community, people continuing to socially distance and wear masks. And this should be very effective in reducing our influenza disease burden and hopefully keep our hospitals less burdened by critical illness from influenza from the people who tend to get really sick. I'm not going to dwell too much on this, just to say these are really different illnesses. Don't let anyone tell you that COVID is just another flu. It's pretty clear that the mortality is much higher by an order of magnitude or more. Year over year, the seasonal influenza mortality rate is about 0.1%. And I've already shown you the numbers we see for COVID. The transmission methods are similar. More people with COVID have asymptomatic virus shedding for 2 days before they're sick, whereas with influenza, although there are a tiny number of people who are subclinical with influenza, most of the contagion rate is after people start coughing and feel bad. And children are very important for the transmission of seasonal flu. There's been some question about how important children are for transmission of COVID-19. I don't think we really know that for sure. That probably has a lot to do with, and maybe Gibbie Harris will address this. I think there's a lot of concern that, this varies by housing conditions, crowding conditions, school conditions. But I think I am worried that we could see an uptick of COVID in the community if children and teenagers are back in school. I'll talk briefly about vaccines and then we'll be done. There's a lot of questions about vaccine development and how durable the benefit's going to be. We really do not know what is the duration of immunity from natural infection from COVID. We know that there have been some case reports of people getting a second case of COVID, including a recent report from Nevada. And we don't know what the duration of protection from the vaccines will be. And so while we can be hopeful, we really need data. And until we have data, I don't think we really know how long we're going to be in this socially distancing and masking situation. Most of the vaccines in development are 2-dose series, 28 days apart. There's one vaccine being developed by Johnson & Johnson and Beth Israel Hospital using an adenovirus vector, single-dose vaccine. There's a lot of hope around this because it's a single dose and it does not need to be frozen, which makes things very much easier for distribution and delivery of the vaccine. Unfortunately, they had to pause the phase 3 trial less than a week ago when one particular subject had an adverse event, and I have not heard if the subject was on placebo or on the vaccine, but they're investigating that. That doesn't mean the vaccine trial is stopped permanently. It just means it's on pause. We don't know if people rush to take the first vaccine on the market, how that will interact with the effectiveness or safety of subsequent vaccines that might be better. And there are no pediatric trials yet starting. And of course, the reason for that is the vaccine trials are targeting the highest risk population for adverse outcomes, but ultimately we'd like to know that children can also get vaccines. I think it's useful to think about how effective are vaccines. We have many highly effective vaccines like the injected polio vaccine, 3-dose series, the measles vaccine, the new zoster vaccine to prevent shingles is very effective. The chickenpox vaccine for children is very effective. And then we've got moderately effective vaccines like the influenza seasonal vaccine and the 2 bacterial pneumonia vaccines. And my concern is we may be looking at a COVID vaccine that's only in the moderately effective range, not in the highly effective range. The NIH COVID Moderna trial is looking at these endpoints. It's looking for evidence of primarily prevention of symptomatic illness after 2 doses. And the secondary endpoints they're looking at for the vaccine are prevention of severe illness, prevention of death, and then prevention of any laboratory confirmed infection, whether asymptomatic or symptomatic. And it's going to be on the merits of the outcome of the study as to whether this gets approved and how promising it really is in providing protection. So I think that's the end of my talk, and I will yield the floor.
Thank you very much, David. And while we get Gibbie's slides up and running, just a reminder to those who may have joined us a little bit late, please, if you have questions for David and then ultimately for Gibbie as well, when she presents her information, please send those questions to me, Howard Glazer, via the private chat function. I'll make sure we get as many questions answered as possible. Before I let Gibbie begin her presentation, just one word about the vaccines. I know there's been a lot of political interest in them as well as medical and scientific in terms of how quickly the vaccine may come on the scene. From my experience of 22 years working for Merck and being involved with physicians doing major clinical trials for medications that sometimes took many years, I think the vaccine story will unfold in a very scientific and very carefully thought out way by the vaccine specialists doing the studies. I don't think there will be political influence. It's too risky for there to be such. And I think the trials will play out over time with the investigators making sure that they have effective and safe vaccines prior to submitting information to the FDA, at least for the general public use. There may be some early emergency use authorization, but I think that we're going to have a safe operation here to do this right worldwide. So anyway, that's my take on it, understanding the whole process of how clinical drug trials and clinical vaccine trials are run. Anyway, thank you. Gibbie, you have your information up. I'll turn the mic over to you. Thank you.
Good evening. Whoops. Okay. I appreciate that, Dr. Weinrib's presentation. Every time I think I know what I need to know about COVID-19, there's more to learn. So really helpful information, I think. What I wanted to do tonight is just talk about some basics from a public health perspective, trying real hard not to duplicate what you've heard already. So just a quick update on where we are in our community with COVID-19. As of this evening, we have had a total of 30,748 confirmed cases of COVID-19 in Mecklenburg County. And we've had 374 deaths. Half of those deaths have come from our long-term care facilities, which is consistent with what you heard earlier about who's most at risk of mortality. But when you look at the half that are coming from the community, a large number of those are in our elderly population, but most of those really have come from our people of color in our community, those who are highest risk, who have the biggest issues with chronic diseases. So again, consistent with what's being seen across the country. This particular slide, these are the cases reported to date, and you can see that we had a fairly significant wave that hit our county in the June and into July timeframe. But if you look, you'll just see just a sort of a tiny little uptick that we're starting to see over here in October, and we're watching that very closely. The one point I will make is that we are seeing increases in our metrics that we follow across the state. And we're seeing that in counties surrounding us as well. We have not seen major changes in our numbers over the last couple of weeks until the last couple of days when our case counts have started going up again. So again, vigilance is what we have to be about these days. This shows you what our hospital census has been in Mecklenburg County since March. And again, we talk about hospitalizations and deaths being lagging indicators. You see our case count go up first, and then our hospitalizations and our death rates sort of follow a couple of weeks to a month afterwards. And that's consistent here as well. We talk a lot about our percent positivity rate, and that's the number of cases of COVID compared to the total number of tests being done. And again, our positivity rate came down late July into August, and we were doing pretty well. And right now, actually, we have been hanging around the 5%, which is what we were shooting for. But as you can see, we're starting to see a minor uptick there as well. So again, something that we've got to watch closely. I just wanted to point this out as well. What you see on the left side of your screen is the leading causes of death in Mecklenburg County in 2019. And these are the things we typically see when we look at this: cancer, heart disease, unintentional injury, stroke, Alzheimer's, COPD. If you'll look at the first 6 months of 2020, you will see that COVID-19 is the third leading cause of death in our county. This is the first time in decades that we've had an infectious disease in the top 10 leading causes of death. So it's something that we've got to keep an eye on and recognize the impact that this is having on our community as a whole. Talking briefly about transmission, I think most folks understand this, but just want to reinforce it. Most spread commonly happens between people who are in close contact with one another. And we're really looking at 6 feet. There's been some discussion through the CDC that there's a possibility that it's a little more aerosolized than we thought it was, and that it might be a little further than 6 feet that you have to worry about droplets being in the air. But at this point, we continue to go with the 6 feet, and that's the reason for the social distancing. It spreads through respiratory droplets. So anytime somebody coughs, sneezes, sings, talks, or breathes, again, another reason why the masks are so important. These particles are inhaled through your nose, your mouth, your airways, lungs, and cause the infection. And this is the main way that the virus spreads. However, we do know that there is the possibility of touching a surface where the virus has dropped onto the surface and then touching your mouth, nose, or eyes. Another reason why we tell people to keep their hands away from their face. I don't know if y'all remember, but early on, the media sort of got on me a little bit because I was pushing my glasses up during a presentation when I was telling people to keep their hands away from their face. So, you know, just remember that that is one potential way of exposure, although it's not a major one. And then the whole issue of community spread. And what we mean by that is there's significant enough virus in the community that you cannot necessarily pinpoint where you pick this up. So it could have been at the grocery store where you were yesterday, or it could have been at church where you were a couple of days before that, or it could have been at that restaurant where you went with your family last night. There's enough of it in our community that it's out there, and you just have to be aware that you're potentially exposed at any point in time. Talking briefly about testing, we do know that testing continues to be widely available in Mecklenburg County. Both of our hospital systems continue to do a good bit of testing in the community. We have a number of sites through CVS Pharmacy, through Walgreens. There are a number of other facilities that provide it. And we are doing some more mobile testing and mass testing in our community as we move into the end of the calendar year. So testing is available, and the good news is that our turnaround times on test results are pretty stable right now. Most folks are getting test results within 48 hours, and the average at this point is 1.3 days, which is great. That's not 48, yeah. Because at one point we were at 7 and 10 days, and at that point it does no good to tell somebody to isolate or quarantine. So this is good news for us. And we are looking for opportunities to test in a number of different ways. We do have the ability to do some mobile testing right now. I've put a website here for anyone who would like to host a drive-through testing event. Please let us know, because we do have the ability to do that. And the more we get out into the community, the greater our ability to get to some of those high-risk folks in our community who don't necessarily come to regular sites. In terms of our guidance, that has not changed. We are asking people who have symptoms. I will tell you that we had an event recently where an individual was involved over a 4-day period of time, thought he had a cold, didn't bother to get tested, was at the event, was not necessarily wearing a mask most of the time, exposed a lot of people, did not have a cold, he had COVID. So if you have symptoms, even though they may be mild, at this point testing is available, people need to get tested. Anyone who's had close contact with someone with or without symptoms, who has COVID, anyone who is higher risk, and we talked about those, whether that's due to your age, your health conditions, or your work environment, if you're around a lot of people and folks aren't wearing masks. And then one of the things we have added is anybody who's recently attended any type of gathering. You may have seen today that Dr. Fauci talked about the fact that we are seeing more and more people being infected by small gatherings in their homes, whether that's with friends, neighbors, or family members that they normally don't spend time with. So we're recommending individuals who are involved in those gatherings to be tested as well. We continue to work with our partners. We continue to make screening available regardless of insurance coverage and an ability to pay. And so we're wanting people to know that testing is available. It's not going to cost you. If you have a copay, that's waived. And if you don't have insurance, you will not be asked to pay for that test. And so if anyone has questions about that, they can always call our public health hotline, which has been available since the beginning of the pandemic. Wanted to talk about mitigation for a minute because we know that we don't have vaccines available at this point. There's been changes. We've gone through our stay-at-home orders. We've gone through our safer at-home orders. We've gone through phase 2, phase 2.5. We're now in phase 3. And the things that stayed the same in phase 3, mass gatherings are still limited to 25 indoors and 50 out. Indoor seating at bars is still closed, although if you watch some of the social media, that's not always the case, but that's what the executive order says. Amusement parks, that is, they're being allowed to be open at 30% at this point. Fitness and exercise facilities, again, open, restaurants open, all of these within certain capacities. Personal care businesses open, museums and aquariums, limited capacity. And face coverings are still required, and people are recommended to social distance. Alcohol sales across the state are supposed to cease at 11 p.m. Until 7 a.m. the following morning. Some of the things that changed in this last phase of this last change of phase 3, meeting spaces in hotels, conference centers, meeting halls, all of those sorts of things, again, are allowed with reduced capacity and other restrictions. Gaming establishments may reopen, limited capacity, and that's bowling alleys, those sorts of things. Theaters are now opened at limited capacity. And the large outdoor facilities such as the Bank of America Stadium are allowed to reopen at 7% capacity. The Panthers had a little over 5,000 people at their last home game here. A lot of these businesses we are working with closely, as well as with the schools and with the courts and with the universities, to review their plans, provide guidance, make sure they have things in place to try to make sure that the public is as safe as they can be when they take advantage of these sorts of things. When we're talking about mitigation, though, we're talking about the risk versus the benefit. I was talking to a brewery owner today who was talking about the fact that he wanted people to understand that they were doing everything they needed to do with cleaning and requiring people to wear masks and social distance, and there was no risk. And I just had to tell him, I said, in our community, because of community spread, there is always a risk. So it's a matter of weighing the risk versus the benefits, and everybody has to do that for themselves. There's recommendations that we make, but you have to weigh those risks against the benefit of doing it. So number one, you need to understand your personal risk. Are you at higher risk because of your age, because of your health conditions, or are you at risk because you're spending time with people that you've not spent time with before and you don't know what their risk is? You need to understand the risk of transmission in your community, and that goes back to our the number of positives per 100,000, which is one of the metrics we look at, as well as the percent positivity rate. And that sort of helps you know what level of transmission there is in your community. You have to decide how important the activity is to you. There's a lot of conversation about Halloween. There's a lot of conversation about Thanksgiving and Christmas. Dr. Fauci did mention today that, you know, these small gatherings in your home can put you at risk if it's with people that you're normally not around. And there are a lot of people talking about rethinking holidays, and whether, especially if you have high-risk members of your family, whether you have virtual Thanksgivings. Hearing a number of people talk about that, and what kind of activities for Halloween. So again, how important is the activity to you? That's part of the benefit, part of this equation. And then understanding the risk to others that you may pose by participating. So if you have a student coming home from college, you have no idea what their potential involvement has been and what the potential risk they may be bringing in something into your community, into your home. And if you have others in your home who are at high risk, you really need to think about how you manage that. So all of these things play into that analysis. The same thing has happened in the conversations with the schools in terms of making decisions about when to bring children back to school. There is risk. We have community spread in our community. We know we're going to have cases once children and teachers come back into school. That's just going to happen because we have COVID in our community. But the question is, what's the balance with the benefit? I know my own grandchildren are hungering for interaction with other kids. I can see it in the interactions they try to have with them on virtual settings. That kind of social interaction is important to them in their development. So how do you balance those things? And that's got to be part of all of that conversation. And I talked about understanding the risk of transmission in our community. And these are a couple of slides that we provided to the schools, but we're using them in a number of settings. So our 7-day COVID-19 case rate per 100,000 sits at 62.5%. Most folks are thinking that 5 to 10 per 100,000 is what you want to shoot for. So obviously, and that's the green, and you can see we're not close to the green with this particular metric. So we continue to have moderate community spread in Mecklenburg County. Now our positivity rate is better than that. And if you remember what I talked about, that is the number of positive tests compared to the total number of tests being done. And we've been hanging down around 5%, which was where we were wanting to be, there or lower. We'll have to watch as our number of positive tests go up, how it affects that number for us. But these two metrics helped make decisions about at least opening to some degree with our school system. So prevention, I sort of say prevention for last, because for me, that is one of the most important things. This is what we can do other than weighing your risk and your benefit to activities. And these are the things that we've been preaching and that everybody knows. You're hearing it from lots of different people, but you need to know how this spreads, because if you know how this spreads, you can avoid as much as possible. You need to wash your hands often. You need to avoid close contact. Cover your mouth and nose with a mask when around others, and wearing masks appropriately is critical. There are a number of people I see, sometimes I just want to tell them to take it off and not to bother, because the way they're wearing it is not helping anybody, them or the people that they're potentially exposing. Covering your coughs and your sneezes, preferably you're not coughing or sneezing into your mask, because it becomes saturated after a while. If you've got those kinds of symptoms, you probably ought to be staying home anyway. Cleaning and disinfecting services, especially those that are used by multiple people on a regular basis. Monitoring your health every day. Know what the symptoms are. And if you start having symptoms, then, or if you know that you've been exposed to somebody who has symptoms, consider getting tested. And I continue to enforce avoiding gatherings as much as you can. This is just an interesting slide that I wanted to share. This was talks about how effective wearing a mask is. There was a study done. 2 hairstylists who had COVID-19 spent at least 15 minutes with 139 clients. And as you can see, no one was infected because they wore masks the entire time. It's just if you wear those masks consistently and correctly, it really does make a huge difference. And so speaking of masks, you need to choose a mask that has 2 or more layers of washable, breathable fabric. A lot of people are wearing gaiters these days. There are a number of gaiters that are being, those neck gaiters that are being created that have 2 or 3 layers. There are a lot of them that had been sold that were just one ply layer. That's not sufficient. But the multiple layers that stays up on your face when you're wearing it, completely covering your nose and your mouth. A lot of people wear it just above the upper lip, leaving their nose out. That does not help. And making sure that it fits snugly around the sides of your face. Don't wear a mask that is vinyl or makes it hard for you to breathe. A lot of people wear these masks that have the exhalation valves. That is not a good mask to wear. Basically, that prevents you from inhaling stuff in but it doesn't prevent you from pushing stuff out. So avoid those with the valves on it. And we have, since the beginning, really encouraged people not to wear N95s or surgical masks if they don't need to, because we need to preserve those for our healthcare providers and for our first responders who really need those because of the exposures that they have every day. We've already talked about flu. What we're seeing in other places is a mild flu season so far, but some of those places where we're seeing that are doing a better job of wearing masks and getting flu shots. So we're pushing flu shots this year. We're wanting people to go ahead and get vaccinated so you don't have to worry about that. Having COVID around is enough to have to worry about. So encourage your family and friends to get their flu shot this year. And at this point, they're readily available. We will be doing some drive-through flu availability a little bit later in October and early November. The state's providing us with some vaccine. We don't know how much yet that can be made available, especially to adults who don't have insurance coverage. And I went ahead and threw the Halloween guidance that we've provided into this just because we're almost there. We really don't want to. My medical director sent me a text message this weekend. She said, my kids are really unhappy with me right now because I told her we were canceling Halloween. So we're not really canceling Halloween. But we do want people to be careful. I mean, if you're going to trick or treat, number one, wear a face mask. And a Halloween mask does not substitute for a face mask. You can decorate your face mask, your cloth covering, if that's what you'd like to do. Or if you can still breathe, you can wear your cloth covering underneath your Halloween mask. We're asking people not to go trick-or-treating where it's crowded, and to do, if you trick-or-treat with other kids, to make sure these are kids that you're normally around, that you're not exposing people unnecessarily, and for folks who are giving out candy, to do that in a way that's safe, so that kids are not all sticking their hands in the same candy bowl, and that they're and that, the candy's probably not being handed to you by the person at the house. So there's a number of different things that we can do. And there's other things that families can do that doesn't necessarily entail going trick-or-treating. And there's some of these are listed here. And the things that we're really asking people not to do really have to do with avoiding crowds and avoiding crowded situations. These are the things that worry me the most. I do think that that's the challenges that we're going to see over Halloween. So hopefully people will pay attention to this. And then most important, and I always end with this, that these are the things that we need everybody to do. I do believe that many in our community have done this. That's how we've gotten our positivity rate down as low as it is. But we've got to continue to do this. And I know everybody is tired of COVID. I know they want it to go away. I know they want life to get back to normal. The more of this we can do, the more we can make sure that our businesses can stay open, that our kids can go back to school, and that we can all be relatively safe as we're trying to weather this winter, because winter is going to be a challenging time for us. So I will stop there so that there's time for questions.
Thank you, Gibbie. Thank you, David. Those are great presentations, and thank you both for trying to maintain a great timeline as well. We have a little over a half hour for questions. I have a lot of questions, and we're going to get to them. If it looks like one or the other of you is specifically designated for a question, I'll let you know. Otherwise, I may let you both comment on a given question. This is an interesting one to start off from Matt Sadinsky, and I may have both of you comment briefly on this. He'd like to know about the truth and consequences of this concept called herd immunity. What do you both think about that? I'll let you start, David, if you'd like.
Well, I think the concept of herd immunity, and Gibbie may be able to speak to some examples of percentages for different diseases. I don't know, have exact numbers off the top of my head, but the concept is if you've got a large preponderance of the community or immune to a particular disease, even if it's not, 90% or 100%, and you've got some vulnerable people who've either are not vaccinated or didn't respond to a vaccine, that they may be functionally protected because everyone in their immediate world, whether it's their classroom or their family unit, are protected. And so they're, in a sense, relatively protected from getting a disease. But that breaks down when more and more people go unvaccinated or more and more people are not immune. The problem with COVID is we are far, far, far away from herd immunity. We still believe, from data I saw a month or more ago, that in North Carolina, we are still well below 10% of the population that's been exposed to COVID. And that's nowhere close to approaching herd immunity. So it is a real phenomenon in vaccine preventable diseases like measles and chickenpox, and I think that but it's predicated on immunity really being protective. And as I said earlier on my vaccine comments, we really don't know how durable and how complete immune protection is from COVID, whether from having acquired the disease once, how truly one is protected and whether that lasts more than a few months or 6 months, or if the vaccines are going to be highly protective. And that gets into the effectiveness of the vaccines.
Gibbie, you want to comment on that herd immunity question?
Sure. And I just want to reiterate a few things that David said. The whole issue of, for those folks who have had COVID, how long does their immunity last? We've seen minimal evidence at this point. There hadn't been enough research obviously done about this, but there's some thought that people can get reinfected at some point. So even though they've had COVID, that doesn't mean that they've got long-term immunity. We just don't know enough about it yet. And that's been one of the challenges with COVID from the beginning. We're learning as we go. Typically, when we're looking at herd immunity, we're looking at least 70% of the population having immunity. And right now, as David said, we think probably less than 10% of North Carolina has had this infection. So we got a long way to go. And if you think about it, if we want to just open things up, as some folks are recommending, and letting those folks who get it and get over it, we're probably looking at a lot more morbidity and mortality than what we would do if we continue to protect ourselves.
Great answers, guys. Thank you both. Next question comes from Rabbi Asher Knight, and Rabbi Knight asked a really interesting question. David, I'll let you comment on this question. There appears to be new evidence that people are being infected twice, with the second infection being worse. Have you seen this, or do you want to just make a general comment about it, David?
Well, I mean, so I hear some feedback from somebody. So I think that this is a rare phenomenon so far. There was just some information from the Nevada Health Department about a Nevada patient who did have a young person without, I think they were in their 20s or 30s with no health problems, like that would put them in those high-risk categories, who has had a documented second attack, and the second illness was worse than the first. But these numbers are so small, I don't think we can make a generalization about either how common this is, or B, what the pattern is in a larger number of people.
Okay, thank you. I'll continue asking you another question, David. It's from Ellen Martin. Ellen wants to know, there appears to be a limited supply of remdesivir at the current time. Is there a plan to get more produced sooner? I know you mentioned that you might be involved in remdesivir studies in pre-hospitalized patients. So I don't know if you have some idea of what the supply chain is like.
Yeah, so I think that the issue is if this drug is FDA approved as effective, I'm sure the company will ramp up manufacture and distribution. The question, of course, is for what stage of illness is it recommended and effective? It is an intravenous medicine daily for 5 days, so it's not like you can go to your Walgreens and just get 5 pills and you're set. It's actually an intravenous medicine. There are some antivirals that are being researched that are tablets and oral. So this drug remdesivir is moderately effective, as I think Anthony Fauci said when it was first announced, when the FDA first announced its emergency use authorization. You know, it's not a home run. It's just a or a silver bullet. It's moderately effective, but in the people it was first tried on. So I think we need more data, but I do suspect the company that makes it would ramp up manufacture and distribution if it is fully FDA approved and able to be prescribed.
Okay, thank you. I'm going to turn to Gibbie now for this interesting question, just to follow up on some of your comments about school-age children. This comes from Dina, who's on her phone. Her question in general says, as a parent of elementary and middle school children, I'm very nervous about sending them back to school next month, especially because our school is planning to have about 16 children in each classroom at a time without the ability to keep the children 6 feet apart. What advice would you give us as we consider whether to go back or stay virtual? I'm sure a lot of parents around Mecklenburg County are thinking and asking the same question.
Yeah, this is a, I'm sorry, I got to plug my computer in before it gives up the ghost. That's a tough call. It really is a tough call. I think middle school students, I mean, we're looking at after Thanksgiving before they come back, or right before Thanksgiving. So they'd be in school for about a month. And I will tell you that we're seeing the likelihood of spread being, seems to be a bit more of an issue across the country in our teenagers, our middle schoolers and high schoolers than it is in our elementary. You know, our child care settings have been open for quite some time, and we haven't seen huge numbers of children becoming infected. And the other thing that we're seeing, because our private schools have been open for a while, as well as some of our colleges, is classroom exposure has not been where we've been seeing cases come from to begin with. They're getting exposed outside. It's outside activities, whether that's sports or some other activity where they're around other people or in their households being exposed. So I think there is, the schools have done a really nice job of putting together plans. What we're seeing in terms of how they've mapped things out in the schools seems to be a good plan. To be honest, my biggest concern right now is buses, because of the changes in how they're talking about bringing children back. We've got more kids in the classroom, less chance to social distance, but we really have little opportunity to social distance on buses because there's going to be more children on buses. And that's one of my bigger concerns right now. So what I will tell you is that we're going to be watching this very closely. We're working with the school system every day on potential cases and making sure that we're pulling children and teachers out of classrooms as fast as anybody shows any type of symptom, and then doing the contact tracing we need to make sure that we're stopping spread before it happens. So it is a decision each parent's going to have to make.
Thank you very much.
Can I
Yes, please.
make a short comment to what she said? And I think this relates to one of the problems we have in the healthcare setting, and I think it applies to schools and life in general. I think that people need to not come to work sick. Parents need to not send their children to school sick. And, you know, there's long been an ethic that people are dedicated to work and they go to work and they don't miss work. and that is the wrong thing to do in this epidemic. I think the same with the schools. If kids have sniffles, if they don't feel well, they should not be going to school. Same with healthcare workers, same with employees. And I think we need to have a whole change of mindset about staying out of work and staying out of school if we're sick.
That's an excellent point. Excellent point.
Thank you both on that. Good, Gibbie.
No, I was just going to say, I mean, we've talked about our schools being little petri dishes because children do come to school sick. This is not the time to do that.
Okay, thank you. Actually, I've got a question that has come in from a few different participants, Sherry, Benjamin, Howard, Epstein among them. I'll let both of you comment on this briefly. I know there's been a lot of talk about this in both the medical literature and in the public newspapers. Is there some information you want to share about an individual's blood type and how they may or may not be affected by COVID-19?
So I can speak to that. There was an article in the New England Journal of Medicine looking at some very sophisticated genetic analysis that indicate that people with O blood type seem to have, so you have to be careful when you do these studies, what's correlation and what's really causation. And there is some biology behind this, but the A blood type seems to be the highest risk among the blood types for bad outcomes. And the O blood type seems to be the lower risk for bad outcomes. But how important that is in the context of all those other risks we know, like, are you 80 years old or 20 years old? And do you have morbid obesity with a BMI over 40, or are you just a little bit overweight? The relative contribution of blood types is not really clear, and it's not necessarily the important or even the second most important factor. But there is some biology behind that, and there has been some studies on that.
Thank you, David. Sticking with you, David, quick question. I know you talked a little bit about monoclonal antibodies. I don't believe this is so, but is there treatment available now, or is it all still under investigation?
It's investigation.
Okay, thank you.
Unless you're the president of the United States, just like some of you may remember, Mickey Mantle seemed to get a liver transplant mighty fast when he needed that. And so, I'll just leave it at that.
Okay. Here's an interesting question as we get very much into the voting season from Alan Gottheim. I'll let you address this, Gibbie, and that is, are face masks going to be required for voting?
So that's a great question, because you'd automatically think, because of the governor's executive order that requires face masks in public, that they would be required, but evidently the Board of Election at the state level had precedent over voting sites of the governor's executive order, and their intent is not to do anything that would deter people from voting. And so they're not requiring face masks. They are recommending face masks. We've worked with the Board of Elections. We were able to get a lot. I mean, I think we had 50,000 masks delivered to all of the voting sites. So if there are people that come without face masks, we can make them available to them. All of the staff that are working the sites are going to be wearing face masks. So we're doing everything we can to encourage it strongly, but it's not absolutely required.
Great answer, Gibbie. Thank you. Here's an interesting question from Joel Nathanson, and I'm sure there are other people on the Zoom call with us tonight who have this same issue. He says, I have year-round allergies whose symptoms mimic many of the COVID symptoms. Any suggestions on testing?
I don't necessarily have a good answer for that, because I have allergies as well. If I mean, this year, the allergies seem to have started in February and haven't stopped. anytime you begin to feel the symptoms and you haven't been having them, I would suggest that you consider getting tested. As I said, there's ample testing out there available in our community right now. It's better to be safe than sorry. And I mentioned earlier too, we've had several situations where people have exposed quite a few people thinking that they just had a cold or it was allergies, and then found out that they had COVID. So I would suggest, especially if it's not been an ongoing symptom of a runny nose or sniffles for you, or itchy eyes or whatever, that you consider being tested. I don't know if David disagrees with that, but.
Yeah, I would just say, you know, the decision has to do both with what is your activity level and exposure likelihood. You know, if you've been very homebound out of choice, and you're not the one going to the grocery store, and you're not going out, and your symptoms are basically stable for what you're used to and respond to your typical allergy medicines, it may not be a reason to go out and get tested. But if it's really out of the norm for your allergy symptoms, and or you have had more exposure risk because you went to a family gathering, or because you went to church / you know, some big gathering or a bar, that may be a good reason to you know, to get tested, because your likelihood of exposure was higher.
Thank you. It's an interesting question, and I think one of you may have touched on it in your formal lecture part of the evening. What's the current thinking of the time the virus survives on surfaces? And I guess surfaces just used generally here, but it seems to be a topic of interest that people like to discuss with each other.
Yeah, I think that I personally think that this is mostly not the major factor to worry about. There's been lots of science looking at different materials, from metals to cardboards to wood and other surfaces. How long can a scientist isolate the virus? That does not practically translate, however, into what is that is what we would call, medically speaking, is that an inoculum? Is that enough to literally self-infect yourself? Furthermore, we know that transmission is mainly by inhalation. I think what I do worry about mostly are high-touch surfaces, like, you know, when I go to work, touching the same doorknob and the same, you know, staircase rail that lots of other people are doing. And so really that gets to hand washing a lot, avoiding rubbing my eyes and touching my face. You saw I wear a goggle at work, so the goggles keep my hands out of my mouth. The mask has the double purpose of preventing me from eating candy at the nursing station. But it also, you know, it keeps me from touching my nose and touching my mouth, because it's a physical reminder there. So that's good. So I would just say, don't worry about the box of Cheerios you bring home from the grocery store. You know, but wash your hands after you come home from the grocery store.
Yeah, I agree with that. I usually have hand sanitizer with me. When I come out of the grocery store, I wash my hands, you know, clean them off. The areas where we have concern are places where there are multiple people using the same computer keyboard or the same telephone in an office setting and things like that. So it's those high touch areas where you know, there are a lot of people putting hands on things, and especially if you're not wearing a mask and don't have those barriers to your mouth and your nose and your eyes, that just creates a potential issue. But again, that is, I really don't think that is a significant risk of exposure compared to being in the choir box with a bunch of other people and singing on Sunday morning. So again, the risk benefit.
Great. Got an interesting question, very short one, but a very important one. And I think others have been thinking about this. And I think I got asked this also prior to the program, that somebody submitted questions. What do both of you think about a mask mandate? Now, that's just a question, so I'm not sure what that means, you know, in general, you know, public use, you know, out and about in the home, just, the concept of mandating that versus a strong suggestion. What are both of your opinions on this?
Everybody ought to be wearing a mask. And I know there are some people, we've had this discussion multiple times, who have challenges wearing a mask, whether it's because of a respiratory condition they have, or some emotional reason for them not to wear a mask. There are some people who have problems wearing a mask. My preference would be that those folks really consider whether they need to be out in public or not. And I know that's challenging, but right now, considering what we have going on in our community, everybody ought to be wearing a mask.
Well,
Just good, David.
I was just going to say, I wish everyone would wear a mask. I think that unfortunately, I think that the consequences. So, what does it mean to mandate? Does that mean the police give you a fine or put you in handcuffs or rough you up? I mean, what does it mean to have a mandate? And truly, I think our public officials have done a good job strongly encouraging it. Some leaders have been better at leading by example. When I have driven out into rural North Carolina, I see a lot less mask wearing than when I see here in Charlotte. And, whether that's just, why people choose not to, I'm not sure. But I really don't think it's wise as public policy to try to enforce it, because I think it only leads to bad outcomes.
Yeah, there's been a lot of discussion about that. And actually the governor's order mandates masks, but does not allow for enforcement of mask wearing for individuals. What it does allow for is, or requires, is businesses to enforce people coming into their business. So I know there have been.
Breaking up a little, Gibbie. We'll wait till Gibbie gets back with us. I'll ask you this question. I was going to ask both of you, but you can comment on this, David. Issues.
We're always going to be more effective if we focus on education and really keeping people focused on doing what's right for themselves and for their community. So.
Thank you. By the way, just as a little break in the questions, I've gotten numerous messages to me and some to everyone about the wonderful job both of you are doing tonight. We really appreciate it. It's an interesting and very important both public health and I think a business related question. This comes from Evan Wilcoff, our Temple Media past president. And I know this hasn't been addressed yet. Have there been any documented cases of transmission due to airplane travel or sitting on an airplane? I guess the broader question is about air travel itself. And I think this is really one that a lot of people on this call have been wrestling with, whether to do or not to do. I'm interested in both of your perspectives from both a medical and a public health perspective.
Well, I will say there's plenty of evidence that other respiratory viruses are spread in close quarters on airplanes like influenza, both at the airport, in crowded airports and onboard airplanes. Airplanes have an advantage of the air being filtered by a HEPA filter, but that doesn't really protect you against the person who's sitting immediately to your left, to your right, or in front of you or behind you. And transmission of other respiratory bacteria have been described, like tuberculosis on airplanes, which are more classically airborne than droplet. So while I can't speak to documented COVID spread, it's basically spread by the same mechanism as influenza, only more contagious. So it is hard for me to believe it would not be spread on an airplane with people sitting next to each other.
What about the filtration systems on the planes? I know they've really been, making a big deal of that as a potential game changer and a safety measure.
Well, but I don't think HEPA filters are new on airplanes. So the problem is you've still got the immediate people within your 6 feet or 10 feet immediacy. And, you know, you've noticed that I haven't flown, but I hear that they've interrupted cabin service because I don't think the airline attendants want to be in your proximity either. So you're handing out snacks. So I think it kind of speaks to, it's not, there's no such thing as zero risk. I mean, there's relative risks. And if everyone on the airplane would wear a mask correctly, maybe goggles or a face shield, that would protect them relatively. But, you know, I think that from what I hear, the airlines aren't, you know, keeping that middle seat empty. They're trying to pack them in if they can.
No, they're not. They're not socially distancing on airplanes. That's for sure. There was a little bit of that in the beginning, but not anymore. And I agree. I mean, we have multiple examples of TB being spread on an airplane, and other types of respiratory issues. And so it is not necessarily whether there's a HEPA filter on the plane or not. It's the close proximity, and you know, they're not serving drinks and snacks for a number of different reasons. I mean, people have to take their masks off to eat and drink. And, you know, even if the attendants were willing to serve the stuff to them, you don't want them taking their masks off. So again, and you know, it's all, again, risk benefit. What kind of risk are you personally already, you know, are you older than 60? Do you have other of these chronic diseases? How long are you going to be on the plane? You know, there's a difference between a puddle jumper and going all the way to California. So, but I do think at this point in time, especially with what we're seeing across the country, the risk of being on a plane is pretty high. And the other thing that I had a conversation with our folks out at the airport, evidently we've got one of the busiest airports in the country right now. There are lots of people in that airport before you even get to the plane. You know, just some things that you need to consider.
A few of the people, this is obviously a very interesting question. A few people commented that, you know, people are wearing masks on the planes, and this seems to be a mitigation concept that people are really buying into, but I respect the comments that both of you have made. This is a really important matter, I think, that really ties the virus in with big business in this country, and it's been quite an issue we've had to deal with. I'm going to give both of you a softball to end the questions tonight. It's a fun question. How often, and just the best way of washing the masks that we're all talking about wearing, do you even wash them, or you just throw them away and get another one? Just unmute yourselves, guys.
Yeah, so I wear a cloth face covering, and I wear one every day. Anytime I come out of my office, or anytime somebody comes into my office, I'm putting that thing on. So I wash them every day. I don't wear surgical masks, and obviously don't have a reason to wear an N95. So my masks stack up and then get washed. I don't wear them more than once a day.
So my practice is at my workplace to sort of use masks efficiently but also conserve them. The request is we keep masks on until we take them off. So if we take them off at lunchtime to eat, we dispose of them and we get a new clean mask. And what I typically do at the end of my shift when I'm leaving is I dispose of my mask, and I sometimes take a mask home with me, leave it in the car, bring it back to work, and then I get a clean mask when I go in. So basically, I'll leave the mask that's clean from my workplace in my car, and then I wear it back into work, and then I get a clean mask to start the day. So I'm mostly using surgical masks in that fashion. I do have some cloth masks for road trips when I go to the mountains or whatever. And I would say they get washed, because they get used relatively little, they get washed accordingly, relatively little, maybe once a week.
You guys were just fantastic. Here's a testament to both of you. We start off with 90 participants, there are 85 of us still with you. That's all I need to say. This was just fantastic. With that, I'm going to turn it over to our other co-president, Brian Emery, to again thank you as well and close the program. Brian, thank you.
Well, it's been quite an evening of learning valuable information that I believe we'll all find beneficial. The Brotherhood would like to thank Dr. David Weinrib and Mecklenburg County Public Health Director Gibbie Harris for an outstanding and informative presentation. We hope their presentation has brought some clarity and addressed concerns you may have about COVID-19. We would also like to thank Howard Glazer for moderating tonight's event and the TBE staff who have coordinated the video. Please know the Brotherhood is developing plans for future presentations of equal impact and interest. These will be announced through Punchbowl and Shule Cloud as we near the dates. Thank you again for your interest and attendance at our COVID-19 presentation, and continue to stay healthy. Have a good night.
Thank you, everybody.
Great. Thank you, folks.
Thank you, David.
Thank you. Everybody stay safe.
You too, Gibby. Thank you. Thank you, David.
Ms. Harris.
Thank you.
Thank you, everyone.
Thank you, Howard.